Morning in Washington. I'm Carol Diamond. Thank you for the lovely introduction, Mark. It's a pleasure to be here, and I really look forward to this discussion. This happens to be a group of people who I could sit for hours and pick their brains on health IT, so I'll be mindful of the timekeeper. To get us started, I'm going to make a couple of comments on the paper that we released a couple of weeks ago at Mark's urging. And I think the paper's available here. About 2 weeks ago, we released a paper with lots of organizations in collaboration on trying to set out an initial definition of meaningful use, what it should mean, how it should be defined, and also on some of the technical requirements for getting these health IT investments in ERA right. And the document lays out a set of principles that really stem from the idea that these health IT investments really ought to lay the groundwork for the kinds of changes we want to see in healthcare and for health reform. That this is an important way to sort of lay the groundwork for some of the things that Mark was talking about, improving quality and reducing the growth in costs. So the document really lays out the idea that the way we define meaningful use should really derive from the goals that we have for the technology. And the principles go on to basically lay out a couple of very important points, which I'm going to just highlight for a minute. The first is that with any technology investment, if you do not define what the goals are up front and make it very clear, the technology rarely delivers on them. So, I know you agree with it. So we really said that it's very important up front to make sure that the goals and objectives of these investments are very clearly stated: improving health and healthcare quality, reducing the growth in costs, stimulating innovation, and protecting privacy. Second, we made a big point in the document of saying that the kinds of changes and the kinds of goals we have are not addressed merely by the installation of hardware and software. They happen because people use information, and the technology is a tool to make better use of information. But it's really the use of information that we're after in making better decisions as patients, as physicians. That's what really leads to better processes and better care processes. We also said the goals need to be achievable now, that there's an urgency. Let's not forget that both the health IT investments and the health reform discussions stem from the economic urgency that we feel because of the proportion of GDP that healthcare continues to occupy. And each of these investments needs to be thought about in that way. We made some points about how to think about the goals of qualified or certified EHR, that they too derive from the goals of the IT, that they really be the manifestation of how it can be demonstrated that the technology can be used and be demonstrated to be achieving those goals. We make a big point in the document of talking about the need for innovation, and more importantly, the need not to thwart innovation. We need innovation both in technology in this space, but also in care delivery. And this really is a moment, I think, with these investments to stimulate that. And we'll get into some of those issues in the panel. Obviously, the way this gets implemented should reflect a broad range of providers. And this panel has a broad range of experience that really reflects the diversity of healthcare and providers and the environments and the technologies that they're going to need and use. And we made a big point in the document of saying there should also be an enablement of lightweight and web-enabled tools that allow practices to make use of things that can be used now to really deliver results and show value. And finally, that we should embrace the role of consumers and patients and families in this. One thing ERA clarifies is the right of an individual to have their electronic information given to them. And we should all be thinking about these investments as really rallying consumers and patients around the same goals that we all share. There's huge untapped potential there. So with that, let me introduce this terrific panel. And we're really going to be talking about the intersection of how IT and health reform really come together. So let me start to my immediate right. Dr. Ron Paulus has the best title I know. He's the Chief Technology Innovation Officer for Geisinger Health System, and he is really responsible for ensuring system-wide innovation at Geisinger. I'm very jealous of that title. Neil Kalman is the President and Chief Executive Officer of the Institute for Family Health, where he has really led the Institute for 26 years. I had to do the math. In developing family health centers and community health centers in New York and the Hudson Valley region. Very fortunate to have Neil here. Peter Newport, as you all may know, is the Corporate Vice President of Health Solutions Group for Microsoft, and he really is responsible for spearheading the strategy for Microsoft in their health care products and services globally. And then finally, last but not least, is Hunt Blair, who's the Deputy Director for Healthcare Reform in the Office of Vermont Health Access in the Agency of Human Services. And in that role, Blair's had a lot of experience with Vermont's experience at the public policy level with health IT. So let's launch into a discussion, and we'll run this hopefully as a discussion. So I encourage the panelists also, if you hear somebody say something you'd like to respond to, please give me a little cue. Each of you obviously has very deep experience in using health IT, but deep experience in very different sectors. And I'd love for you to reflect a little bit on that experience first from your own organizational vantage point, whether it's an integrated delivery system or looking at a consumer platform, state policy making, or community health centers or underserved populations. And introduce yourself a little bit by sharing sort of your story, your experience with IT, and where it's taken you, and what you feel the most critical issues have been, as you've used information technology in your respective roles. What are the most critical issues that have led to the kinds of improvements that we're talking about today? So, Ron, do you want to start?
Sure. Thanks for the introduction, Carol. And my kids are enamored with that title, too. They perceive it as I just get to screw around at work all day. But I guess I'm a little bit atypical relative to a health system individual. By way of full disclosure, I'm a recovering vendor. So I spent 13 years co-founding and co-leading a company called Care Science that was focused around hospital quality and efficiency transformation. And truly, it was that experience that I think, ultimately led me to Geisinger, because some of the frustrations and successes that we'd had at Care Science served the foundation for lessons learned. And what I knew at Care Science was that we delivered the same product and the same service in every single hospital client, and we had over 200 clients in 38 states. And yet the results that were achieved with that product were fundamentally different. So that some people were able to achieve, order of magnitude changes in quality and efficiency. Some had modest improvements, and some had no improvements at all. That ultimately led in our company environment the development of a consulting division to help support and nurture and educate some of those clients. But the takeaway message, and I think this is apropos for the whole issue of health reform, is technology is necessary, not sufficient. And it's the framework within technology is deployed and how it's used to change organizational dynamics and ultimately how Mr. Jones or Mrs. Smith is taken care of that makes the difference. At Geisinger, I've been there now 4 years, so much of the spade work was done ahead of time, and so I just got to go in and sort of, have the fun of trying to re-engineer things on top of a multi-year post-implementation electronic health record platform. And so what I'm truly responsible for is meaningful use. How do we take advantage of this investment, over $120 million that's been made to change the way care is delivered? And so, that's the experience that I have. That's the lessons learned. And I'm sure over the course of the discussion, I'll share more of that experience.
Great. Neil?
Well, I guess if you're a recovering vendor, I'm a recovering family physician who used to practice on paper. And now, fortunately, practice in a completely electronic environment. And what most people might think would be an unusual setting to be able to do that, I run a community health center network, as you heard, in New York City and up the Hudson Valley. that basically takes care of the poorest people, lots of people who are uninsured and on Medicaid. And in 2002, made a commitment to take our entire system electronic, and a big bang sort of approach where we implemented this across all of our centers in a period of 2 months after extensive training, but implemented it and literally did it for 2 reasons. One was I was running a network that spanned 150 miles, and it scared the hell out of me to figure out whether or not people were actually delivering good care across this network. And I thought, how am I going to ever know? We had acquired a bunch of centers that we hadn't started, and how am I going to ever know whether people are actually maintaining control of their diabetic patients? How would I know whether the providers were doing a good job, whether people were being lost to follow-up? And I thought, well, the only way to really do this is to put in a fully functional electronic health record system. The other thing was that we had been doing work on health disparities with a grant from the Center for Disease Control for about a dozen years. And one of the things that we learned from our work in disparities was there were 2 very important issues. One was that people in the communities that we took care of didn't trust the healthcare system. They'd been mistreated. They had felt like they were second-class citizens almost everywhere they went in the healthcare system. And we thought, what could we do with electronic health records that would actually help people trust the healthcare system more? And the second aspect of that was communication. People really felt, and when we interviewed people work with disparities, that really they weren't being communicated to about their healthcare issues. And we thought this is another great potential use of electronic health records. So really, to deal with the issue of disparities and to deal with the issue of quality sort of monitoring, and at the time we weren't really even thinking about improvement. But what it's really morphed into over time for us is really a focus on 4 areas, and this is where we've sort of put our electronic health record to work. One is quality improvement now. So we report every month on 42 different outcome-based measures that are trended month by month and have now been trended for almost 4 years. So we can not only monitor quality but see how it's trending based upon the things that we're doing both through our electronic health record but also through other work we do on quality improvement, and see what impact it's having on which centers, on which providers. Coupled with quality is another piece that we call equality, which is making sure that everybody gets the same outcomes. And I'm sure all of you are familiar with data on health disparities, and although a lot of times when you look at systems, people are all getting the same treatment, they all don't achieve the same outcomes. And so that held true. We looked at data in our own system, and we now report by race and ethnicity all 43 measures on a monthly basis, so we can track the special things we're doing to focus on historically underserved populations. The third area is around patient communication. And we've been trying to figure out all of the ways that electronic health records can be used to improve communication with patients, starting with, on sort of the trust access, generating after-visit summaries that actually have a copy of the note that we write about the patient on a daily basis. So people actually get a copy of what we're putting in the electronic health record as well as their labs and other things, which we'll probably go into later. And finally, and very importantly, in terms of what we did, a very early commitment to linking up to the public health care system in New York to try to use the information that we have in our system to inform public health about the kinds of things that we are seeing, because as you all know, diseases are often first and most severely experienced in underserved populations. And second of all, to be able to take the information that public health has about what's going on in our communities and put it right in front of providers at the point of care so that they know what things are happening in the community, what kind of outbreaks there are, what kind of diseases there are. Now we're working on what kind of even antibiotic sensitivities there are to common infections. So there's a lot of opportunity, and I guess the message I would say is all of this stuff is not pie in the sky. It can be done now with existing systems. And this is, those are our definitions of meaningful use within our own delivery system.
Great. Thank you. Peter.
Great story. Love to hear all that. I'm a recovering vendor. I'm still just a vendor, and I'm happy to position Microsoft.
It's a halfway house.
I'm happy to position Microsoft as lightweight and web-enabled. It's a new positioning for it. We're really trying to do a couple of things. And in our experience, when, we're in the business, as I think everybody else is, to try to help save lives. Technology has transformed every industry that we participate in. Think about this. It's being webcast live. Anybody can pick it up on demand. That's pretty cool. But why hasn't technology transformed health in as effective a way as other industries? And I think it has lots to do with incentives and payment reform. And what are the right kinds of technologies that can allow the kinds of outcomes at the right costs? Because it's not only do you have to get it adopted and used, you have to do it at the right price point with the right flexibility and the right architecture. In the enterprise, we have two businesses. I know you want me to talk about consumer, and I love to talk about consumer all the time, but I think it's really important to start within the enterprise and say, how do you get real-time data? How do you get real-time data around quality so that you can do it during the treatment, during the procedure, while the patient's still there, and not just as a reporting measure? Mm-hmm. And we believe that's doable today, and we're delivering real-time quality information systems for some of the large health systems around. But when I look at how do you get consumers engaged, and a person said it well, medicine is a team sport, and the consumer is a key member of the team. And actually, it's not just the consumer, it's the consumer's family. When you think that 75% of the costs are around chronic conditions, you need to change behavior. What are the attributes? And so being communicated with, being in the home, being able to connect a data platform for the physician and for the consumer, and so that they can see the same state, the same perspective, the same understanding, so that you can get the right kinds of communication and trust is really important. So we launched Health Vault, which is a way to do that in a way that allows for value to be created on top of it about 18 months ago, and we can talk more about how that can be an effective place for people to start to connect the links of this disconnected system.
Right. Han.
So everybody's talking about what they were recovering from something. I'm a recovering shy person, so not only in front of a room, but with the webcast. So I've been in state government since January, but I've been involved in Vermont's policy development around HIT and healthcare reform since before the beginning of it. We have been working on healthcare reform efforts in Vermont for quite a while, and we're glad to see the rest of the country catching up with us. And we're also really excited about the fact that what we consider to be the first national healthcare reform bill that was passed this year, the High-Tech Act portion of the era, recognize the integration of health information technology policy with healthcare reform policy more broadly. In Vermont, we, from the very beginning, have been focused on how to use IT as a tool to drive system change and integration. IT is really just, it's a means to an end for integrating healthcare, public health, and as has been mentioned, the people who are getting the care, we the people. And so that's has been really the animating force of what we've been doing. And so our healthcare reform is all about building and fostering systemness, because as we know, we don't have a healthcare system. And digitizing and exchanging health data is a core building block for actually being able to have systemness. You just can't have a meaningful system integration without health IT.
Great. Okay. So I want to come back to an issue that each of you raised in some way. And really not, before we get to the issue of incentives, really the issue that I heard each of you say in different ways, which was it is possible today. We can use IT to improve quality and health. We do live in a world today where there aren't systemic incentives anyway. But each of you has been able to figure something out about making sure that the IT delivers on those goals. So what is it? What's the secret sauce? And what have you been able to really make sure happens in your implementation? You want to start?
Sure. So I'll use our medical home example, not because it's the latest fad or buzzword, but because I think it lays out the true opportunity for an integrated IT plus care coordination plus incentives. And so, we follow a mantra at Geisinger that says eliminate what you can, automate what you can eliminate, delegate to the lowest cost competent caregiver, and activate and engage the patient and the family in the overall process. So those were the central tenets of the approach. And in this medical home approach, we have our primary care sites, and we've done this now for non-Geisinger practices as well as Geisinger, so it's not just this hermetically sealed, unique, unreproducible environment. And we've embedded a care management nurse directly into the practices, and that care management nurse that's paid for by the health plan, plus the doctors and the clinical team that care for the patients, plus the patient, plus the health plan care coordination team, all use the same electronic health record platform. So what does that mean? We started with the tenets of what the goals were. We said we want to improve care coordination, we want to improve cost efficiency, we want to improve objective quality metrics, and we want to reward all of those behaviors in a combination. So we started out with a strategy and with observable objective metrics that can be used to measure whether we're achieving the strategy. And then we put the financing in place because the health plan pre-funded the care management nurse, stipends to the doctor, stipends to the practice site, and provided a cost-sharing savings mechanism so that if PMPM spend was down over time, and if and only if quality metrics were up commensurately, that there was a sharing opportunity. And so that started from the process of strategy to metrics to goals to workflow change in the vernacular of IT, changing the care process itself. And what have we been able to achieve? Well, the article's in peer review currently, but the gist of it is substantial reductions in all-cause admissions, dramatic reductions in readmissions, a 5 to 7% PMPM trend delta that's been sustainable for more than 2 years across both Geisinger and non-Geisinger sites, more than 30 sites in total, and substantial improvements both statistically from baseline as well as comparative to the market in objective quality measures. So that sort of highlights what can be done, but IT was just an enabler. It wasn't a magic pixie dust that was sprinkled into the practices. It was, given how we want to re-engineer care, what can we do to leverage this core infrastructure platform to make it possible?
Great. Neil, you had...
I'm laughing because, it's the incentives are all aligned when you have some risk associated with it, financial risk, and you can take some of the savings and use them to actually support the development of IT and quality improvement, and you get good outcomes. And I think in our system, we have no connection at all to sort of quality incentives. Nobody's paying it to us. The people that are actually looking at those things are, every single health plan has their own things that they look at, and they pay, 50 cents if you can achieve some amazing outcome with 1,000 patients. And it doesn't really come close to investing, and yet we've done almost exactly the same things that you have. Used the same system across all parts of our delivery system, including we run 3 community mental health practices. And so the mental health records and people's primary care records are both in the same system and are available, so people really truly integrate mental health care with primary care, which is really interesting. But to sort of come back to the question you posed, Carol, I think that for us the big challenge has been to stay focused on the end game. It's like which of the, every time we're sitting around the room and somebody goes, this would be really cool, let's do this. I go, so which of our 4 objectives is that really going to help? Are we working to improve quality? Is it going to do something to reduce disparities? Is it helping us connect better to our patients? Or is it somehow helping public health? And, if you sort of stay focused on those, and the reason why cost isn't there is because I think, as you just mentioned, cost is really an outcome of providing better care. And so, I really have not seen developments of IT systems that are specifically engaged in reducing costs. They reduce costs by helping people coordinate care better and giving better care across the system. So those are the things that sort of we keep in place. And I guess if there were 2 lessons learned, one is stay focused on what the mission of the technology is, because it's so easy, like with all of these things, to kind of get swept up in the technology itself. And And the second would really be how critical it is to sort of provide leadership within organizations. You know, whether you're the innovation leader or the president, somebody needs to be able to stand in front of the company and say, this is the direction we're moving. Adoption of this technology is not an option. We've spent $3 million this year, on technology. And yes, doctors, I have 120 primary care doctors working for me. They do not have an option whether they like to use the system or not. If they don't want to use the system, there are plenty of other opportunities, job opportunities available in the community. But we literally, have stayed focused on the mission by saying we believe in the technology, we believe in what it can do, and we mandate that people use it. And that took place from day one. And I'll just a quick little quip on the implementation. We literally, the day of implementation, went into all of the exam rooms before opening, took out all the prescription pads, all the lab order forms, all the progress notes. People would open up their drawer, and it would be empty. Not even a pen. And literally, you used the system or you couldn't practice. And I say that because I think there are so many stories about investments in the technology. So the other piece for us is if we're investing it as an organization, then you have to take leadership and demand that it's used to meet the outcomes that you've invested for.
So, Peter, I wonder if you could respond also, but I'd also be interested in your thoughts on what Neil just said, because what he's really talking about is possible at the organizational level, but we know so much of healthcare is fragmented, small practices, and the kind of both leadership and goal setting and direction isn't as easy to organize in that environment. So I wonder if you could react to that a little bit.
Well, as the technology guy on the panel, it's really tough to say it's not about the technology. Come on. But I agree with you. It's not about the technology as much as a fun, shiny object it is. And it is really all about leadership. But so we said, who can lead, right? Who can lead and who is empowered or motivated or thoughtful about, geez, I'd really like to make sure I'm getting better care. And so we focused first on the consumer and trying to empower the consumer to be a partner in demanding the right metrics, in demanding the right outcomes, in participating in a way. And consumers react in lots of really silly, stupid ways. Is why am I filling out the dumb clipboard again? This is a whole part of the trust thing. Is I was just in here 2 weeks ago and I have to fill out the same damn thing. Well, this is crazy. Is nobody paying attention? Or I'm getting prescriptions from 3 different doctors and bad things are happening, and why can't they talk? Well, if they're not going to talk, then I'm going to take control. So this is about how do we empower the consumer. And so we've tried to say, because there isn't leadership across the non-system, is there a way for us to empower the consumer to get educated enough, informed enough to be able to be a change agent, a leader in demanding the types of understanding and care that they deserve. And that's what the goal of a consumer, personally controlled health record management system is to enable the consumer and or an agent of the consumer to help them be a better partner inside the health system. And I think it can be an organizing principle. It simplifies many things. We have done a lot of the hard work of transformation, systems, standards, all that other kind of stuff, and just make it simple for the data sharing at the point of care where real things happen. And that is a way to get started from an organizing point of view.
So, Hunter, I wonder if you could react to that a little bit from the state point of view, since that's a different locus.
Right. So the good thing about having a visionary legislature is that they put forward a enormous vision for transforming our healthcare environment into a system. And the challenge, of course, is that to re-engineer care on a statewide across a fragmented non-system, we don't have the advantage that Neil had of, okay, docs, you can go work elsewhere, or because we have a hard enough time getting physicians to come to our rural practices. And we didn't have the kind of advantage that a system like Geisinger has. So what we did was say, a lot of the legislators said, why can't we just have like a single EHR for the entire state and we'll be done? And, which in a controlled environment you can do, but in absent that, And a state certainly is not a controlled environment. You can't do that. So what we did instead was develop a set of standards and an architecture for interoperability, and sort of focused on, again, the ends that we were trying to achieve in terms of integration of the system. And a lot of that started out with what we call in Vermont the Blueprint for Health, are what started as a chronic disease management and care coordination program, and has grown into being basically a vehicle for practice transformation more broadly. And so we have used how the payment reforms and other practice transformation components that are related to the blueprint have pushed forward, and I mean push actually, on practitioners to motivate change. And we can talk more about the sort of financial structure about that later.
So let's stay on this issue for a minute, though, on sort of setting the goals and the right leadership, and sort of saying, this is the direction we're going. And let's look ahead now to sort of the opportunity at hand, both in the health IT investments, in the stimulus legislation, and in the discussions that are being had now about health reform. Is there a proxy for what you're talking about to create a sense of coordinated systemness, collective goal setting in these opportunities that we should seize on? In other words, is there a way to create in this fragmented system, through these two very big investments and moments in the health IT history, is there a way to use this moment to get to what you were saying, Neil, about making it work in the environment that you had?
Well, I guess my perspective is quite simple. It's basically just get everybody to do what we're doing. And
all right, then.
Self-evident. So time up. I think quite seriously, and we've been talking about this now incessantly for weeks. But I think how you started, Carol, is exactly where we need to be. We need to test every little piece of what we're doing. Every time we're talking about specifications, every time we're talking about exchange, to say to ourselves, what are we exchanging this for, and how is it going to benefit patients that this information is being passed? And I was in a discussion last night with a group of people, and every time you ask this question, about 50% of the things that we're currently talking about doing fail that test. Nobody around the table could say, how will this actually work to improve the outcomes that people are having? How will it actually work to create a more equitable healthcare system for everybody? How will it work to reduce? And you find that you're engaged in a lot of stuff about technology that neither helps to empower people or helps to improve care. And I think if we just stay focused on that, it will set the path for us in the right way. And the other thing that I think is critical is that if government weren't involved, then there were no stimulus dollars or nothing. This is a train that's moving. And so I like to think about what is our role in terms of using those dollars to alter the natural path of that train in ways that would help to better meet the ends that the public needs from us, because these are tax dollars and we need to use them responsibly. And so how you use them responsibly, in my mind, is to say, here's the way the train's going. We don't need to put any dollars necessarily behind that, but what do we need to do to sort of tweak that a little bit to sort of make sure we get the outcomes that are required when you put this kind of an investment into something?
So in some ways, Neil has said what the most important metric is, which is to ask at every level of this implementation, how is this helping patients? How is this achieving the goal? How is this improving quality?
Well, which implies that there's specifically articulated goals that can be measured. Because, I think at a simplistic level, we focused a lot around the country around interoperability and around certification and other things that are all important. But the question is, what's the end? And process is necessary, not sufficient. And so, you know, in a simplistic way, one could argue that if you have technology that exists, which I believe that we do, it can be better, it'll get better, you know, that's going to happen natively. If we define what the goals are, and if we align incentives toward those goals, so, you know, the ultimate stage of meaningful use is, to me, not use. It's just, did you achieve the goal or didn't you? And at that point, people will either adopt or not adopt because the outcome will be the evidence for success.
So I agree that the most important thing is to measure, right? And then decide what are the important things that you want to measure. And you picked outcomes, and I think that's really important. To say, and I agree that technology will help us get there, I want to put a plug in for, it's not clear to me that we have the right technology today. I think we can do stuff today, and I actually think we can do, but what you spend on it, how it empowers doctors, how it empowers patients matters. How you have an environment for innovation, because where we are today is one spot. Where we need to be 10 years from today is a very different spot.
Absolutely.
And we need a rapid cycle innovation. We need a learning health system. We may be able to measure 42 things, but a lot of disease we don't understand well enough, and we need to be able to get the data to understand empirically and scientifically how can we do things even better on this train that we're going. So I think it's really important to think about the framework that gets put in place while we deploy what we have today and not get it stuck. And too often things that get deployed get stuck, and innovation slows down. And I think we need a rapid innovation environment around doing better, what works, and better understanding. And so I think measuring, delivering, innovating are important characteristics.
I think what you said, the critical piece that I hear and what we're so involved in is not just producing the data, but how do you actually use that data to improve the quality of care? And that's not just getting it or looking at it. It's system transformation, even within the practices, the kind that you described, and that goes far beyond coordination. It goes to outreach. It goes to getting people to motivate behavior change. It goes to all kinds of things that we really haven't considered yet. But as you start to look at your data and you see that it's sort of flatlined and it's not improving, then all of a sudden you realize you need the innovations around quality improvement that really drive the system to perform better. And I think that's the critical issue. And that's where I think the technology of improvement, which isn't just about the computers, is really what we need to be focused on.
So to just paraphrase for a minute, I think what you're saying, and I completely agree with it, but I want to emphasize it, is that the end goal is not the measurement. The end goal is the improvement, but without the measurement, it's hard to change care processes. And it's analogous to the statement we've been making about technology. The end goal is not the adoption of technology. The end goal is the use of technology to improve health and healthcare. Well, actually, the end goal is the improvement of health and healthcare. Technology may be a tool to do that, right?
And so the role of government actually is incredibly important in framing this, because it's not going to happen on its own. I mean, we've seen that. I mean, there have been great innovations made in isolated areas, as represented right here on the panel, but we haven't sort of taken that next step. And so that's why I think it's just incredibly exciting that we're at this point now where we're sort of poised because of the clear federal policy direction, which we're now starting to reflect in the state. So, for instance, in Vermont, initially, we delegated authority to our private partner, public-private partnership, our state RIO. We had them both assigned to write the state health information technology plan and to operate the health information exchange. And what ended up happening is they got completely, they could not differentiate between their organizational goals as an exchange and the broader policy goals. And so things got very muddled. And we've taken the opportunity of the national legislation we just passed earlier this month, state legislation that's basically a little mini version of the first couple of sections of the High-Tech Act that place authority and vision for our expectations for everybody at the state level. And that, in turn, is going to provide the impetus. I guess it's not going to happen on its own, is the point. And so this will drive that rapid cycle innovation. Paradoxically, I mean, it's kind of funny. We have a business group in Vermont that traditionally is highly suspicious of the government becoming more involved in healthcare. They've been not exactly warmly embracing some of our healthcare reform initiatives. Some they're okay with, but paradoxically, they have completely supported, and we've gotten there was no opposition whatsoever to the state basically taken back over the steering wheel of HIT policy. So that I think people recognize that it's a bigger mission and vision that we're trying to accomplish here that is precisely all healthcare delivery and care transformation.
So let's take up that sort of challenge that you raised, which is there isn't always, we don't always see the success that we see on this panel. And let me ask each of you to think about sort of the opportunity at hand today, the health reform discussions, the many policy panels and other opportunities that you're all participating in, and talk about what you think or what you'd like to see happen in order to make your experiences more the norm. In other words, what can happen at the public policy level to address the issue that Hunt is raising? Yeah.
Well, I think we have to align payment incentives. And I think that goes beyond sort of just incentivizing people to adopt EHRs. I think you align payment incentives either through something like the accountable care organizations, you align payment incentives through integrated systems, or you align payment incentives for physicians based upon outcomes. Then, all of a sudden, one day they wake up and they realize they cannot achieve those outcomes without the technology. And I think that's ultimately what it is. Right now, you can still be in business, you can still be a doc, you can still do what you need to do and function fairly well without having an electronic health record. The thing that makes that different is if we create a system where you just can't do the things you need to do every day. You can't write prescriptions because the only way prescriptions can be done is electronically. You can't get the kind of incentives in place for integrating care because the expectation is that care is integrated and at least enabled through the kind of systems coordination. And you can't get incentives unless you put the patient at the center of your delivery system. And so you realize that unless patients have access to their health information through your patient portal, unless you're printing information in your exam rooms for people to use for health education purposes, or giving them access to their records through, Microsoft or that other company, then unless you're doing that, then I think basically you can't do that without IT. So I would say those are the things that we need to sort of drive as expectations of a delivery system, that it's patient-centered, that it deals with quality, equality, all that stuff, and then people will wake up one morning and realize, you know what, in today's environment, I can't really practice unless I'm electronically enabled. And I also think the new generation of docs just won't have it any other way. They're just, none of the residents that practice in our 2 residency programs have ever worked with paper. They don't even know what it is to have a paper record. We show them some of these things that are in our storage room, and, they're like, what is that? So I think part of the moving train is just with technology, that stuff's going to morph with time.
Yeah, I would echo that. I mean, I think, as many have said, you get the system that you designed for, and so our system is designed to deliver volume and skin and orifice penetrations, because procedures are what drives, business today, and so people react in a natural way to those incentives. I think establishing, what the incentive framework is to achieve the outcome goals, and then letting people innovate in their own way. I think the overwhelming majority will drive towards technology solutions because it's a proven method to get there. But if somebody can achieve it without that, I don't know why we need to prescribe one particular solution over another. And I think, the last plug I'd like to get in is, we talk a lot about the technology, but one of the key attributes of the technology is that it's collecting and aggregating data. And that data asset that comes from that store, I believe personally, is the most valuable aspect of the entire thing, because that's what we can mine to generate our performance metrics, the trending, We've begun to try to do predictive models. We have a model for congestive heart failure looking at predicting in advance who's going to develop it. For those statistically minded, it has an ROC curve of 0.8, 18 months in advance, just from the pure EHR data, no biomarkers. So that needs to be a part of this overall, framework.
And improvement of processes.
Yep.
Any other?
Well, Ron said my whole speech. It's perfect. It's about the data. And it's really about, we have to think that over time, medicine is going to be very different. When you think about personalized medicine, individualized medicine, the amount of data that you need to have to be able to deliver on the benefits, which will be better for us as a population society from a cost and from an individual point of view, you really need to imagine data-driven medicine, real-time data-driven medicine. And so the one thing I would say is we can do a lot more today, as you've described, but that we have to really make sure that we change the frame of the conversation from records to data and the insights that you, and information. So it means the information. You're always getting to the end. What is right? Like that. But that's really important because there's so much we don't know. There's so much we don't know that we can know if we measured and had the right output. And I agree completely that set the framework and the right technology stuff will happen. Set the wrong framework and the wrong technology stuff will happen.
Well, I think this is going to happen at two different levels, though, because, the average patient isn't sitting around thinking, boy, they're not managing my data well. They're not, there's not a connection directly between data. And, the reason healthcare reform happened in Vermont and is happening nationally is because people are fed up. They don't like how things work. Now, a method for transforming how things work is absolutely data-driven medicine. So one of the transformation vehicles that we've used in Vermont is tied to payment reform, and is actually this is what's kicked things into gear. So we have a medical home, just like every other state in the country practically is starting some kind of medical home. But our medical home has a couple of unique attributes. First of all, it's tied to something called a community care team. So it recognizes that a practice on itself is not going to be able to do all of the care coordination and make all the linkages that need to happen. And we utilize health information exchange between the EHRs, the medical homes, and the community care teams. We have registries, patient management tools tying those things together. And most importantly, we have multi-payer support for both the medical home and the community care team. So all the payers in the state, including Medicaid, and Medicare is not paying directly, although the state of Vermont general funds insanely are paying Medicare's share at the moment. We'd like to see that change. That's a broader healthcare reform agenda, but Medicare participation in multi-payer initiatives. But what's happening is that the practices are making these changes that are going to lead to better consumer interaction, that's driving the data transformation, rather than, although I guess to sort of then contradict what I said at the beginning, I think that once you have this infrastructure there, then people are very excited about being able to access that themselves through portals, through PHRs, and that's ultimately going to continue to drive the change. But it doesn't start with, from a consumer point of view.
Great. Well, I think we have a few minutes. 1 minute for questions. I'm not a very harsh timekeeper, so you can go wherever you saw the hand first.
Thank you for a great panel. Majd Olon from the Center for Aging Services Technologies. You mentioned in the beginning of the panel that a meaningful use implies exchange of health information to attain the goals that we set for the system. So my question is, how are you thinking about exchange of information with a long-term care sector, which is the sector that serves the most costly proportion of the segment of the population, where significant amount of care coordination, medication management, medication administration, chronic care management takes place. So exchanging information with that sector seems to me an important aspect. And interoperability standards for long-term care, HIT, and the certification process is necessary but is not sufficient. Alignment of incentives would also need to follow for that sector. And thirdly, I believe that we need to take this opportunity of the ARA to ensure that the long-term care sector has the infrastructure to enable the seamless flow of information between these settings. So my question is to Neil and Ron. What are you doing outside of the medical home system? What kind of interchange of information do you have with the long-term care sector in your...
Yeah, I'll comment on that because it's an important point. And in point of fact, our medical home model includes an embedded nurse practitioner and or physician in the long-term care and skilled nursing facilities who maintain that as a framework for their practice. We do release information. We provide direct electronic access to those long-term and skilled nursing facilities into the electronic health record, as well as providing, what we call a release of information, which is a contemporaneous with discharge release of major interventions, any medication change, specific follow-up actions that are available at the time of discharge, literally, and it's the only time where we've had people calling up, signing up to be trained, which was when we made this information available to those very crucial constituents, as you know, in the market.
We all wish this for our relatives. Neil, do you want to answer?
That's okay, no.
Okay. Another question? Right here.
My name is Dmitry Novik. It seems to me we discuss a wrong question, how to help medical administrators. We need to help doctors and patients. And by the way, it's very simple. You use such device. You use microphone. You use wire connection, maybe wireless connection. Transform to digital file. That's it. And I don't want the doctor will have in his hands a laptop and type something. It's wrong ideas.
Yes, we agree. We need to do a much better job in making it easier for physicians.
And everything is ready. Before you discuss how to measure success, you need to know what you will apply. It seems to me discussion is not to the point.
Should we take one more question?
Yeah, maybe time for one more quickly.
Okay, one more in the back.
Josh Seidner from the Center for Information Therapy. To build on Neil's point that really what we're trying to get at is how is this going to benefit patients. I think it's a great place to start for the definition of meaningful use. I think all of you mentioned the need to engage consumers. Peter talked about the need to have consumers demand things. Neil talked about specific things like after-visit summaries. I'm wondering if you can talk about some more specific demonstrations of things that would constitute meaningful use in terms of consumers getting access to meaningful, useful information that can help them take better care of themselves.
Well, I'll jump in on that, and even though I'm not in the provider side, is that it is the same of what we've been talking about, maybe at too high a level, which is about encouraging the right outcomes. And the consumer is an important part of being able to deliver those outcomes. And I think, as Neil described, is you need different activities for different types of consumers because of the way they interact with systems of authority, with the health system, and all those kinds of things. And so you need a toolbox of tools that allow you to educate, motivate, incentivize, and communicate with consumers so that they can improve and change their behavior. The right metric is, at the end of the day, did you make a difference? And the difference is in some outcome-based measure of, are they doing the right things? Are they following the things? Are they healthier?
So I think that one of the critical aspects is how we allow people access to their information. So the simplest, I guess, the way, I won't say simple, but the way you start is by you open up a portal to your information or you export it somewhere so people can have access to it. But then that doesn't get you where you need to go because you realize that hasn't really dealt with language access issues, which we're all dealing with in our delivery systems, but we're delivering all of our information in English. So now we have to start thinking about how do we actually do that. And then people start opening up their lab data and they want to know what a CBC is. And so we're now working on a linkage with the National Library of Medicine, Medline Plus, so that every little detail that they view in their record has a hot link to Medline Plus and to the ability to get information, hopefully in multiple languages going forward, so that they can actually understand the things that they now have access to. And then I think finally we have to figure out what kind of, it's not just enough to give people information, we have to get them motivated too. And I think the science of the future is how do you use the technology once people access this, what is it that we can actually deliver that will assist in motivating people to change and to do the things that they not just to be able to view their information, but actually to take some action on it.
Okay. Please join me in thanking this terrific panel.
Thanks.
Thank you.